Thank you very much. Good afternoon. It's nice to be here. I'm not used to standing behind a podium. I probably feel the need to wander about a little bit, so rein me back in if it gets too bad. I'm a pharmacist working with Powys Health Board. I used to be a community pharmacist, since made the move to working in primary care, but I still genuinely believe that community pharmacy has a great deal to offer the NHS in meeting unmet needs. Okay. I don't think anybody here isn't aware of the fact that smoking is bad for you, okay, and quitting is really good for you. Problem is, this is Powys here. Powys is huge. Okay, geographically it's very sparse, it's very rural in nature, there's no cities, we don't have any DGHs, community hospitals only. We do have an existing stop smoking service provided by Stop Smoking Wales. Unfortunately, the number of counsellors that we have means that we get this bit and this bit receives some kind of intermittent service regularly. Fortunately, they've been able to expand on that slightly, but it's a challenge. It's a challenge doing that. Okay, so what we wanted to do was to see whether or not we could meet that unmet need to help people quit smoking using community pharmacies. Now, it's something that I've been trying to do for some time, but there's always been a barrier in the way. There's always been something stopping us going. And I think primarily it was experience with the service and funding. And what happened to push this forward was that in October 2010, the Welsh Government made available some funding via its Rural Health Fund. We made an application to that Rural Health Fund, when we turned down, but then we were fortunate enough to be awarded funding later on again. I don't really understand that. But we actually managed to start a pilot of a community pharmacy-based smoking cessation service. Fundamentally, it's a very simple service. Okay? Trained pharmacists provide advice and support and, where necessary, nicotine replacement therapy to members of the public who are just wandering to their pharmacy or are sent there by other healthcare professionals. It's a 12-week program. They get continuing support. That's it in a nutshell. It's not a complicated service. And the initial funding we had was for a 3-month pilot, so we started that pilot in January. The interim results we got in March actually suggested that we were onto a good thing, that the public seemed to like this service, the pharmacy seemed to like this service, and it was actually doing its job in that it was helping people to quit smoking. So we decided to extend it further, and then the secondary evaluations became successful, that they showed that it was successful and in fact improving, so we carried on going, we kept on building with it. And so we're at the stage now where we're looking to have 16 of our 23 community pharmacies providing this service by the end of this year. Okay. One of the things I'm most proud of with this project is that it wasn't just the health board, and I don't stand here as a representative of the health board. I think I'm here really as the person that helped coordinate this scheme, that there's so many people that helped to make it a success. At the very centre of that body there are 7 enthusiastic and fully committed community pharmacists and their staff who desperately wanted to make this service a success. Without them, this would not have gone anywhere. Okay, so they are fundamentally key to this. Public Health Wales were able to help with evidence and support and an evaluation of the initial trial. The Institute of Rural Health also helped by gathering information from the pharmacists themselves and qualitative and quantitative data that helped us demonstrate this service was a success. We had professional training provided by the Welsh Centre for Pharmacy Education. They made sure that all the pharmacists had nationally recognised accredited training, and other healthcare professionals were confident in their ability to provide this service. The Rural Health Fund obviously provided the initial pump priming that we needed to get this service off the ground. Stop Smoking Wales, this was quite interesting. To begin with, they were slightly nervous about our service because ultimately you could say that we're competing for the same resource, but we felt it was key to work with them to identify situations in which the pharmacy service would be most successful. So we picked areas where we thought it would work and areas where we thought it wouldn't work so well. So we really helped it. They helped us with training, and we managed to build an ongoing relationship, and now they're very supportive of the pharmacy scheme. And again, Community Pharmacy Wales helped really to get the whole ball rolling and helped us to agree on a service specification that worked for pharmacies and for the public as well. Last but not least, I know sometimes it's a dirty word in the top corner, but pharma industry have actually been incredibly supportive of this scheme, and they wanted nothing from us. They provided us with financial assistance, with training support, with ongoing material support. It's not over-egging the pudding, I think, but without any of those individual components, including pharma, we wouldn't have managed to get the scheme going for it to be the success that it is. Okay. NICE says that a stop smoking service should aim for a quit rate at 4 weeks of about 35%. Okay? In the original 3-month pilot, and this was the first 3 months that these pharmacies had ever provided this service, from a completely cold start, they achieved a 44% quit rate. Okay? And this quit rate was validated by carbon monoxide measurements, so it wasn't a self-reported quit rate, which can have some issues in it. Since then, the same pharmacists have managed to build up their experience, their staff are more experienced, they're more comfortable with how the scheme works, and the quit rate has actually risen to a very impressive 52%. Okay? Now, anybody who delivers a stop smoking service or knows things about them, know that's a very, very good quit rate indeed, but I certainly feel it is. Okay? Some feedback here from some pharmacy clients. Okay? This was overwhelmingly positive. We gave clients the option to, or the opportunity to feedback in both a paper-based format and using an online web tool as well to give us their views about the pharmacy service, and it was universally very, very positive indeed. I think we had 90% of clients rated the service as excellent. Okay. Mostly in terms of accessibility, I think the ability just to walk into a pharmacy and be seen by a qualified healthcare professional who can help you there and then to make the first steps towards quitting. Okay. We've also managed, again, going back to our relationship with pharma, they've been very supportive in helping us to get a Powys-wide media campaign. Every home in Powys which is near to a pharmacy that provides the service gets a leaflet through their door which explains the benefits of stopping smoking, identifies where those pharmacies are. So that's really, getting the message out there is one of the things that's been really important. It was something that we weren't very good at to begin with, but as we've gone on with this, we've actually managed to get much better at it and certainly become a little bit more media savvy. It's not without its problems, obviously. Stop Smoking Wales, I think, it would be nice. I'm not saying Stop Smoking Wales is a problem, it's an opportunity, okay? It's an opportunity to get more integrated with Stop Smoking Wales. I don't see why there doesn't exist the opportunity in Wales for a single integrated stop smoking service that utilises the expertise contained within community pharmacies and specially trained stop smoking counsellors as well when that's necessary. It would be good for me if we could take away this element of competition, whether it's real or perceived, and just have a single service. GPs and nursing, I think it's true to say that where GPs have engaged with the service and where they've believed in the pharmacist providing the service, they've directed their patients towards that service as their stop smoking service of choice. Okay? 2 pharmacies where the GPs are very, very engaged deliver more than 50% of the overall number of clients for the entire service. Okay? So GP engagement is vital. Nursing, midwife, health visitors also, it's important to try to get them on board to feed into the service, and that's something that we need to improve at. Secondary care, and to be completely honest, is something that we failed miserably at. Okay? There isn't a comprehensive secondary care structure in Powys. We don't have district general hospitals, and that's something that we've really struggled to take advantage of. When we started, we wanted to treat before the op, you know, to encourage post-operative smoking cessation, and that's something that we haven't really been particularly successful at, and we do need to work harder. Government targets. Sometimes I think it's difficult to see how areas are actually going to reach quite challenging Welsh Government targets for smoking cessation. In Powys, I think to get down to a smoking cessation rate of 16%, we need 5,000 quits in the next few years. The pharmacy service in Stop Smoking Wales is delivering by itself probably about 300, 400 a year. There's obviously something significant that needs to be done to build on the success that we're having. We need to integrate these services more into general healthcare if we're actually going to get anywhere near approaching those targets. Another one that everybody always has a good go at is sustainable funding. Okay? What we've got here is a service that works, that the public likes, that the pharmacy likes to deliver, it's cost effective and it delivers and results, but its funding is not secure because ultimately it doesn't deliver in the short term, it doesn't deliver against cost effective targets for health organisations, and so sustainable funding is necessary if health boards and pharmacies are going to invest in this service going forward and make sure they can continue to provide it. That's it, in a nutshell. Any questions?
Okay, so very comprehensive run through, and certainly for myself and Sue, that really captured, I think, those discussions we had with you when we came up to visit you on site, so to speak. So thank you for that. Questions from the gathering here? If you'd say who you are as well before you start.
Yeah, Martin Seven from the Royal College of Nursing. You give a 4-week quit rate.
Mm-hmm.
As an ex-smoker, I'm conscious of the return rate happening very, very much later than that. I wonder if you want to be data on that.
It was actually what we intended to do, was to build in a 52-week follow-up to that. That's actually proved to be a challenge in the way the scheme works at the moment. Because patients are not registered with individual pharmacies, they kind of drop in, many of them drop in for this 12-week programme and then drop out and don't use those pharmacy services again necessarily on a regular basis. Ongoing contact has been an issue, and so we don't have any firm data at that 52-week rate. We're trying to build something into the service where we guarantee a degree of follow-up and try to get an idea of that continuing quit rate. But you're right, that 4-week quit rate is certainly not reflective of the long-term outcomes for these clients, but that is a weakness that we have.
I'm Andrew Goodall, Chief Executive of our Health Board. I was interested in your take on the relationship with the pharmaceutical industry. And it does feel in Wales that whenever we talk about having a sort of a commercial or a private relationship with somebody, everybody hesitates.
Yeah.
Reality for us in the NHS in Wales is we spend about £800 million on drugs, we spend on consumables, we spend on products, and we get stuff from suppliers. So do you think we can broaden that out a bit differently, particularly in this current financial environment I guess we're working in? I mean, you said you've got to find the right balance of support, but not feeling as though you suddenly have to purchase lots of things from them.
Absolutely, absolutely. I don't know whether it's perhaps my private sector background as a community pharmacist, but I don't appear to have some of the baggage that my long-term NHS colleagues have with integration with the pharmaceutical industry. I think the pharmaceutical industry, in my mind, has changed a lot over the last 4 or 5 years, and now they want to work with people to change chronic conditions management rather than get something from them. It's our primary partners in this have been Pfizer and GlaxoSmithKline, and at no stage have they ever asked anything from us whatsoever. They've simply contributed their expertise and their time, and they've never asked a single thing from us other than to recognise their involvement. They want to be part of a successful programme, and that's all they want. I think there's the opportunity to take it from stop smoking and look at all kinds of services we deliver in the NHS. The pharmaceutical industry has massive expertise in some areas that the NHS isn't particularly good at tapping into. They have figures on tap, they have experts that they can call in at a moment's notice to advise on this scenario or that. I think it's crazy not to take advantage of someone so skilled when actually all they want to do is help. But you're right, you do need to strike a balance, because there are those companies that will give with one hand and expect something with the other. In my experience, they're very easy to spot, and this was not one of those relationships.
Yes, Paul, very opportune.
Paul Gimson from the Royal Pharmaceutical Society, so obviously really pleased to see this. Just a quick comment and a question is I guess one of the advantages of this scheme, going back to your slide with the picture of the map, was the geographical spread of pharmacy across the health board. So this sort of schemes like this tend to be successful because of obviously the services provided, but because you're taking advantage of where pharmacy is positioned across that's the case with this. And the second point was given that this seems to be a very successful model, has the local health board considered using the model for other public health services?
Okay. Firstly, you're right. The spread of community pharmacies in Powys is certainly one of the more equitable services that we provide. There are pharmacies from north to south and even in the middle where nobody appears to live. But they allow us ready access to a resource which can deliver high quality healthcare on the high street. And I know that's something that's often said about community pharmacies, but the feedback that we had from the public suggested this was a key factor for them. They could go in somewhere without an appointment and see a healthcare professional on the street in their lunch hour on a Saturday morning and be delivered a high quality service. So I think in that regard, community pharmacists met our needs exactly. Extending this to other public healthcare services, yes. I think smoking was the obvious one, in that the public is very aware of the harms associated with smoking, and it's not actually very difficult to approach somebody who smokes and offer them the chance to quit, because 70% of smokers want to quit and will try every year, so that's quite easy to think about. I think looking at alcohol and looking at obesity is slightly more tricky. I think the model stands to content is perhaps more challenging for pharmacies to get involved in. You know what I mean? There's a reluctance perhaps in speaking to some of the people who've delivered this service. There's a reluctance to necessarily pitch forward head first into dealing with obesity and alcohol management. That potentially has an impact on their relationships with their clients, and not in a positive way if it's not done carefully.
I think one of the things that struck us, just picking up what you were saying about using community pharmacy perhaps for other initiatives, was the flexibility of using community pharmacy for a rural population and actually being able to directly address issues about access to services, inequalities and things like that. Do you think this particular programme is something that's unique and to a rural community and that's why it works so well, or do you think it could have actual application in a different type of area because the principles are the same?
Well, I want to do myself out of a job here, but actually this isn't new. What we've done isn't brand new, it's not cutting edge science. We are building on work that's been done by other organisations previously. What we've done is we've taken a scheme which is successful, we've tailored it for rural communities, we've amended it in a way that allows it to be delivered, taking into account the staffing difficulties and the access difficulties in rural areas. We've amended it, we've supported it, we've engaged with the partners that we need to, and we've actually had a successful service. I think there's no reason why any health board, provided this is something they want to address, and I can't see why they wouldn't, could just take this model, pick it up and integrate it somewhere else. It's not so specific to a rural environment that it doesn't just work everywhere else. I think part of the reason it does work very well is because we're a rural environment, and we did make those changes to improve the accessibility. That's made it very successful. But those benefits would also occur in Cardiff or Newport or Monmouth.
Thank you. Any other points that anybody might? Oh, yeah. Martin.
You said that there's training provided pharmacists, and if necessary, nicotine replacement therapy can be given.
Yep.
So that means it's an option at some point, but not necessarily a requirement. So what are the other services provided as part of the programme, if not a pharmaceutical intervention?
Right, okay. The programme consists basically of an initial 30-minute consultation with a qualified accredited pharmacist or a qualified accredited pharmacy technician. And there they try to build up an understanding of the client's smoking behaviour, the reasons why they want to quit, try to establish an idea of their current level of commitment. They provide advice, information on the benefits of stopping, the harms of smoking, so on and so forth, and motivational advice that helps them to take that first step. If that client then wants to use nicotine replacement therapy, which in fairness the vast majority do in the high 90s, very few patients don't want to do that, then the pharmacy will provide that for them free of charge and monitor that ongoing use as they go forward. In response to some demand from clients, we actually bolted on an extra part of the service where the pharmacies were able to provide support and information and monitoring to patients being prescribed Champix by their GP. Because what we found is that patients prescribed Champix, and only those who've tried repeatedly to stop smoking found it very difficult and need something a little bit extra from their GP maybe that the pharmacy can't offer. But those very same patients weren't initially able to access the pharmacy scheme because it was nicotine replacement therapy only. GPs didn't really have the time or the resources to provide them with ongoing support, so the neediest smokers who found it hardest to quit were being given the least amount of support. So we redesigned the service that allowed them to directly access the pharmacy scheme, and we've had some quite positive results from that in a number of areas. So there are ways of building on what we've already got, and we take into account feedback from clients and really demand from pharmacies. They drive this service, they phone me up and say, we've got patients who want this, clients who want that, can we do it, can we do it? And we review the spec and we move on. We work with our education providers and try to fill in the gaps, because ultimately we're trying to meet the needs of our population, not deliver a service that we think is right, but a service that meets the needs of those who use it.
Can I ask one last question?
Very quickly, because we're almost out of time.
Is there a longevity, like a cut-off point for how long someone can receive nicotine replacement therapy?
Our program is a 12-week program. Okay, so the last follow-up is at the end of week 12. Really, that kind of prepares the person for life beyond the program, and by that point, if a patient has reached that 12-week stage, they're quite likely to be able to manage beyond that point without formal pharmacy support. In practice, pharmacies provide non-formal support to those clients should they come back in. There's still a professional person who provides them with advice and support, but not in a structured way as under the service. I think should the person need any more formal support, they can be referred on to Stop Smoking Wales, where perhaps behavioural therapy is needed more than the motivational therapy that's provided in the pharmacy. So certainly there's not a cut-off where they're just thrown out into the cold. They're either managed informally, and lots of these pharmacies have very good relationships with their local clients, or they're referred elsewhere if additional support is needed.
Thank you, Jason. You were very quick when we came to meet you to give credit to everybody else involved in this scheme. And I think it's been quite clear today as well from your presentation that you've really led this and driven it, and I think you should be congratulated on that. So thank you for a very interesting